Welcome back to Forgotten Infection Friday. Today we're going to talk about another infection that can come from the ground beneath your feet, and it's called melioidosis. Melioidosis. Let me just spell it. Melioidosis. Melioidosis. And for anyone caring about patients who have diabetes, chronic wounds, or diabetic foot ulcers, this infection is worth knowing, in my opinion, because melioidosis can mimic other infections and can present as a skin or soft tissue infection. It can involve bone abscesses and can spread through the bloodstream. And in some patients, it can become a chronic infection that looks very remarkably similar to tuberculosis again, or even a non-healing diabetic foot infection. So today we're asking, could that diabetic foot infection be something else? So this is Forgotten Infection Friday. So what is melioidosis? So melioidosis, right now I'm not saying it properly, but forgive me, is an infectious disease caused by the bacterium Burkholderia pseudomallei. Okay, and this is a gram-negative environmental bacterium that lives naturally in the soil and the surface water, particularly in tropical areas and subtropical regions. The organism is particularly associated with areas of South Asia and Northern Australia, but causes have been reported in other parts of the world like South Asia, Africa, the Caribbean, and the Americas. And here's what makes it quite interesting. The infection doesn't necessarily require a dramatic exposure. A person may come in contact with contaminated soil or water and not realize that they were exposed at all. And the organism can enter the body through cuts, abrasions of the skin, open wounds, contact with contaminated water or soil, inhalation of contaminated dust or water droplets, and less commonly could even be through ingestion. And what becomes particularly important is that when we're talking about diabetic foot, but because a patient with diabetes, they may already have an open ulcer, right? Or and not feel it, and they may have because of neuropathy, and they could be walking barefoot. That's why we tell you now walk barefoot. And they may have a garden, they may work in the soil. So this may, have no idea that the environment around them could be carrying such a potentially pathogenic infection. Okay, but this is not fear mongering. So, how was melioidosis discovered? So, let's go back more than a century. Melioidosis was discovered or first described in 1912 in Burma, now known as Myanmar, and a British pathologist named Alfred Whitmore and his colleague, I cannot pronounce that name, forgive me, but I'm going to just spell it Krishwami, Krishnamai. Okay, I did not pronounce that well, so forgive me. If anybody has a name similar to that, forgive me. I did not pronounce that right, but I spelled it out. At that time, they were investigating diseases on the patients that look very remarkably similar to tuberculosis. The patients could have fever, weight loss, abscesses, pneumonia, and chronic illness. But something didn't quite fit, and the organism they found was quite different, and it produced a disease that could be acute and rapidly fatal, or even chronic or deceptive. But the disease became known as Whitmore's disease after the man Alfred Whitmore. Go figures, he named it after himself. And the story of the name, how it became known as melioidosis, is quite fascinating. So the Greek root is melis, that means distemper of I don't want to say the word. It's a Okay, just look it up, melis, and oid, which means resembling. And the name was chosen because the disease was recognized as resembling something called glanders, Glander, right? And glanders is an infection that is historically associated with horses and other animals that look like horses, like goats, so I believe donkeys, okay? So glanders is a rare, highly infectious and often fatal bacterial disease that is caused by Burkholderia mallei. Okay, it's very similar. And it affects animals, particularly in the horse family, but it can spread to humans and other mammals through contact with infected body fluids. Okay. And the term melioidosis means the disease resembling glanders. Okay. And the bacterium itself is eventually named Burkholderia pseudomallei, okay, the one that we get, right, humans, because the word pseudomallei essentially means that it's resembling the mallee, which is from the one that the horses get infected with, right? The bacterium that causes the glanders that affects the horse family, okay? And even though the scientific name tells a story, but particularly this organism is recognized as the bacterial cousin of the organism that is responsible for glanders that happens in horses. So why is this melioidosis considered a great mimicker? So it doesn't have one presentation. It can look like many different diseases. So a patient can present with pneumonia, sepsis, a soft tissue infection, a deep abscess, osteomyelitis, and a chronic infection resembling tuberculosis. And with a combination of this, or the infection can be acute, that meaning the patient can become severely ill over a short period of time, or chronic, that the infection can smolder there for weeks or months, or even become latent or reactivated. In some cases, the disease can appear long after initial exposure, although the precise mechanism frequency of the true latent period versus a prolonged incubation and reactivation remain an ongoing study for this. So this variety is one of the reasons melioidosis can be missed, because a patient with diabetes or a chronic foot wound may simply be labeled by having a typical diabetic foot infection. But what if the organism that's causing this infection isn't the usual suspect, but could be Burkholderia pseudomallei? So, what are the symptoms? So, melioidosis can present in many ways. Symptoms depend on which organs are involved. Patients may experience fever, chills, sweating, fatigue, weight loss, cough, shortness of breath, chest pain, abdominal symptoms, muscle, joint pain, skin ulcers, abscesses, cellulitis like lesions, bone, or joint infection. In severe cases, patients do develop sepsis, and sepsis from melioidosis can be life threatening. Pulmonary disease may resemble bacterial pneumonia and tuberculosis. Skin and soft tissue disease from it may look like an ordinary wound infection. Osteomyelitis can resemble other causes, simple other causes for chronic infection. So that's why the clinical picture alone of this disease or infection is not enough. So let's talk about its connection to diabetes. So when we talk about a patient population that concerns us most about when it comes to disease, people with diabetes, we know that diabetes is one of the most important risk factors for something like this, like melioidosis. In many endemic regions, diabetes is strongly associated with increased risk of developing severe diseases. Okay, and why is that? Because the relationship between diabetes and these very rare disorders are quite complex. But as we know, diabetes can impair multiple aspects of the host immune function. Okay, the hyperglycemia can affect the immune function. The neutrophil function is already impaired. The body ability to respond effectively to infection is usually compromised, and patients with diabetes may also have the risk of things like chronic kidney disease, chronic lung disease, alcohol use. Older age affects it as well as other conditions that can affect your immune function. So adding a diabetic foot in ulcer, right? The patient may have a break in the skin, a potentially compromised immune system, and potential exposure to contaminated soil or water could affect this as well. So potentially like having neuropathy that prevents the patient from noticing that the wound or the environmental exposures are at risk, right? So this combination creates a scenario where melioidosis deserves consideration, especially in endemic areas or in patients with relevant such as travel or environmental exposure. So how does soil cause this infection? So this is where melioidosis become quite interesting. So like we said, the organism, the bacterium that causes this is Burkholderia pseudomallei that exists naturally in the environment. It can be in the soil, the mud, or the surface water. And the contaminated environments, imagine a person walking barefoot, like I said, and they have a diabetic foot ulcer. They don't know. It's a portal or entry, pretty much. Okay. And this is why environmental history, taking down a patient's environmental history, matters a lot when we are thinking about how to treat the wound. Because when we're evaluating unusual diabetic foot infection, we have to ask, where does this patient live? Where have they traveled? Do they have a garden? Do they work with soil? Do they walk barefoot? Most likely, yes. Don't we all walk barefoot, right? And have they been exposed to flood waters? Have they been in contact with contaminated or muddy waters? Okay. These are questions to ask to help change our differential diagnosis. So the incubation period for melioidosis. So how long does it take after exposure for melioidosis to appear? So the incubation period is typically 2 to 4 weeks, but it can be highly variable. So symptoms may develop within days after exposure. In other cases, illness may appear much later. So this variability can make the environmental connection difficult to recognize. So a patient may not remember the exact exposure and they may have been gardening a few weeks ago. They may have walked barefoot through wet soil a few weeks ago. They may have been exposed to flood water. And by the time the infection develops, this event may seem completely unrelated to the patient. So, this is in some cases, the disease may present long after the presumed exposure, making the diagnosis even more challenging. And this is why taking a detailed environmental and travel history is quite important when we're treating wounds. So how can melioidosis be misdiagnosed? So interesting enough, let's say a patient with diabetes presents with a chronic wound. There's redness, drainage, and maybe have swelling. There may be an abscess and maybe even osteomyelitis. And the initial diagnosis is diabetic foot infection. And the diagnosis may be correct on a broader sense, but we're going to ask what organism is actually causing it. So the infection may be incorrectly assumed by being caused by a usual organism, the usual suspects that are associated with diabetic foot infections. But melioidosis requires a very different treatment strategy. So, if the organism isn't identified, the patient may receive antibiotics that don't adequately treat the infection. And this is one of the major concerns. So, melioidosis can be mistaken for routine bacterial cellulitis, a diabetic foot infection, tuberculosis, a chronic infection, pseudomonas, osteomyelitis, and other abscess formation. And in endemic regions, clinicians may need to keep melioidosis in their differential diagnosis pocket when the clinical picture doesn't have or the clinical picture of the infection doesn't behave as expected. Think about the patient, if they don't improve with the standard therapy, if they have recurrent abscesses, if they have a unusual or multiple sites of infection, if they have chronic osteomyelitis or have a history of environmental exposure, these should trigger a diagnosis rethink. So how do we diagnose melioidosis? So the gold standard for diagnosis is culture of the Burkholderia pseudomallei from the clinical specimen. So, depending on the infection, samples may include blood, sputum, wound specimens, pus from the abscess, even urine or other infected tissue or blood fluids. And for a diabetic foot infection, properly collected deep tissue specimen or bone specimen when clinically indicated is generally more informative than a superficial wound swab. And, laboratory identification of the B pseudomallei is quite critical if it is actually that. So this is where communication with microbiology laboratory matters because the organisms can be misidentified. The laboratories need to be aware of the possibility that you may think it's melioidosis so that it can properly identify and confirm the testing, okay? And other diagnostic methods can include molecular tests, serology, may be used in certain settings, but availability and performance may vary, right? So the key message is cultures matter, right? And melioidosis, if suspected, the laboratory needs to know. So melioidosis and a diabetic foot. So let's bring it back to what we care about right now, the foot. So imagine a patient with diabetes with a chronic ulcer. The wound has been present for weeks. They receive multiple courses of antibiotics. The wound improves temporarily, but then worsens, and the patient develops swelling, abscess forms, and imagine suggesting osteomyelitis. And the patient has a history of gardening and walking barefoot, and they live or recently traveled to a region where melioidosis does occur, and suddenly the diagnosis looks different. This isn't just a routine diabetic foot infection. Melioidosis can cause soft tissue infection, abscess formation, osteomyelitis, and even septic arthritis. So, and even systemic infection. So, while melioidosis is not among the most common causes of a diabetic foot infection, it is important that unusual causes are considered in the right eh, epidemiological and clinical setting, especially when the infection is persistent, recurrent, unusually severe, or failing the expected treatment. Okay. So, how do they treat melioidosis? So, melioidosis gets very different from standard diabetic foot infection treatment. So the treatment generally occurs in two phases. Phase one is intensive therapy, which is the initial treatment using intravenous antibiotics. Common options for this is ceftazidime or meropenem, and depending on the severity of the disease and the clinical situation. And in severe infections, meropenem is favored. Don't we love meropenem? And this is for intensive phase that generally lasts about at least 2 weeks, but the treatment can be substantially longer, often 4 to 8 weeks. That's why we need infectious disease on this type of patient. We're always going to need infectious disease. And for example, let's say the patient has the osteomyelitis with this, okay, they may require prolonged therapy. That's why we have to go with infectious disease recommendations. And then phase two is eradication therapy. So after initial intravenous phase, the patient transitions to oral therapy to eliminate the remaining bacteria and reduce the risk of relapse. And the most commonly oral agent for this is bacterium. Okay. And the duration depends on the infection, and it may be several months for deep-seated infections such as osteomyelitis. But this phase two is quite critical because melioidosis has significant high risk of relapse or recurrence if the treatment is inadequate. So this is another reason why correctly identifying the organism is so important. This simply, doesn't isn't a matter of choosing the next antibiotic for the diabetic foot infection. The treatment needs to be specifically directed towards the Burkholderia pseudomallei. So what about surgery? So of course, antibiotics are essential for the treatment of this type of organism, but source control may be necessary, such as incision and drainage, debridement of the infected tissue or non-viable tissue, surgical management of the osteomyelitis, and management of the necrotic tissue. So this is particularly relevant in diabetic foot disease because the principles of wound care still apply. We need to assess the perfusion, the neuropathy, the offloading, the infection, the debridement, and the bone involvement. And when melioidosis is suspected, the microbiology diagnosis becomes quite crucial and critical because the infection isn't just about removing the dead tissue, it's about identifying the organism and giving the correct antimicrobial therapy for the appropriate duration. So, how do we prevent melioidosis? So, there's currently no widely available vaccine for melioidosis. So, prevention focuses on reducing exposure. That's why we tell you to not walk barefoot. Just don't. It saves a lot of feet by just not walking barefoot, but also checking your shoes before you put them on. During certain periods or seasons, insects like to hide in our shoes, things like that. So, for people at higher risk, especially those with diabetes, we have to do the important precautions that include wearing protective footwear even outdoors or even indoors, okay? Avoid direct contact with contaminated soil or muddy waters when possible. Wear gloves when you're gardening or working with soil. Cover up your wounds with waterproof dressings, okay? Keep your wounds clean. Avoid exposing open wounds to soil or standing water. And in areas where melioidosis is endemic, extra caution should be taken during periods of heavy rainfall, if there's hurricanes, extreme flooding, things like that that can cause increased environmental exposure. And for healthcare providers, prevention means something else. We got to think about it. We have to ask our patients how their environment is, if they have recent travel, ask about soil exposure, water exposure, and ask whether the infection is behaving the way you expect it to do. So the take home message is, could that be a diabetic foot infection? Actually, gotta ask the question, could it be something else? And sometimes it's yes. So melioidosis may not be the first diagnosis that comes in mind, but in the right patient, it should be on the radar, especially, when we have diabetes, a chronic wound, or unusual wound, environmental exposure to soil or surface water, a history of travel, or the residence in endemic area, abscess, osteomyelitis, or failure to respond to conventional antibiotics. And infection simply doesn't, or if the infection simply doesn't make sense, okay? Because sometimes the clue isn't in the wound, it's actually in the soil, right? And sometimes the most important question isn't what antibiotics should I give, but it actually is what organism am I actually treating? And when it comes to melioidosis, is a reminder that diabetic foot infections aren't always predictable. Sometimes the environment writes the story for the wound, and sometimes the soil holds the answer. And sometimes saving a limb, you have to know what you're looking for. So I'm Dr. G. This has been Diabetic Foot Files. And until next time, and thank you for listening to Forgotten Infection Friday. Keep looking beyond the obvious. That's the whole point of having wisdom, right? Looking beyond the obvious, using our knowledge to be able to decipher things, because infection, that you can forget about might be the one you actually need to remember. And this has been Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you.